Okay. So to begin, we'll speak about the first sibling I met. We'll call her Tanya for the case. And I met her at around 17 years of age. And she began after a normal neonatal course, as well as early development, to be hyperactive and distractible at 2 years of age. Then she began to have intractable seizures at 3 years of age, initially impaired aware, and then generalized tonic-clonic seizures by 3.5 years of age. At that point, we also noticed language regression, and where she previously was able to speak 2 to 3 word sentences, eventually she lost the ability to speak entirely. Motor regression was noted a little bit later at 4 years of age, where she lost the ability to walk by 5 years of age, and then stopped crawling by 6 years of age. Her EEGs initially showed some multifocal spikes with background slowing, and then worsened over time to severe background slowing with several events captured that were not seizures. You can see here in the more advanced phase of her disease, significant cerebral as well as cerebellar atrophy consistent with the underlying condition. So what was the underlying condition? At first, we were only able to do enzyme analysis for one particular enzyme associated with Batten disease, in particular TPP1 or tripeptidyl peptidase 1 enzyme analysis that was abnormal, or she had TPP1 deficiency. Molecular genetic testing was attempted later, but was ultimately non-diagnostic. First, since this low enzyme is associated with CLN2 Batten disease, one of the genetic subtypes of Batten disease, it was negative even after reanalysis. And when looking not only for sequence variants or letter changes within the book or within the gene, seeing if whole sections of DNA were copied or duplicated or deleted was also negative. And so what was the diagnosis? Ultimately, we had enzyme activity deficiency or a TPP1 deficiency, which was consistent with a biochemical diagnosis of CLN2 disease, but ultimately the genotype was unknown. And we'll go back to this genotype question in a little bit. So what are the most common causes of regression in toddlers? This is one study from the United Kingdom looking not only at a general UK population, but also a Pakistani population within their country. And they defined regression here more of what we would see in a pediatric neurology clinic. Not only progressive loss of skills over at least 3 months of intellectual and or developmental abilities, but also the development of abnormal neurologic signs. So not just an autistic regression is ultimately what I'm trying to tease apart here. And you can see, at least within this cohort of 381 individuals, the most common cause of neurologic regression was the neuronal ceroid lipofuscinosis. So have to consider NCLs in the differential when there's regression, including neurologic features. And you can interestingly see, certainly relevant to my area, many other lysosomal storage disorders ranging from Sanfilippo syndrome, metachromatic leukodystrophy, as well as Niemann-Pick type C, but also other types of leukodystrophies, whether it's X-linked adrenal leukodystrophy and vanishing white matter disease, but also mitochondrial disorders. Now, in comparison to a different population, you can see that mitochondrial disorders are more highly represented, and it could just be about common rare variants within a given genetic pool, unclear, but still neuronal ceroid lipofuscinoses remain one of the most common causes of neurologic regression in toddlers. And so let's talk a little bit more about neuronal ceroid lipofuscinoses. This is named because of ceroid lipofuscin, or this material that builds up within neurons. You can see on the right upper hand corner, under UV light, these this autofluorescent material within neurons. And on Luxol fast blue stains, you can see ceroid lipofuscin deposits appear. It's rare as a group of disorders, 1 in 100,000, and affects many parts of the body. Most commonly, the retina and the central nervous system, but can also involve the peripheral nervous system, heart, as well as other organs. And initially, it was described based upon age of onset, whether it's early infantile or infantile, late infantile, juvenile, and adult, but has been more recently described based upon the underlying genetic defect or subtype. And so now we most commonly refer to them by their genetic subtype of 13, most commonly ranging from CLN1 or ceroid lipofuscinosis neuronal, just spelled differently to make medical students' lives confusing. CLN1 through 14, but CLN9, excuse me, was actually a misnomer because it actually was just a different variant of CLN5. Most of these are autosomal recessive, but CLN4 is dominant. All these genetic subtypes encode proteins that are somehow involved in lysosomal function. Sometimes they are lysosomal enzymes like CLN2, as in the case that we discussed here, or CLN13, but they also can be transmembrane proteins or soluble proteins that may not have an enzymatic function. And so this relates to how can we actually intervene? We can't just give enzyme replacement for all of these types of disorders because some of these are just transmembrane proteins, and it can be hard to get these proteins to where they need to go, namely neurons. So to further clarify or demystify this issue about Batten disease or NCL terminology, we have on the left-hand side the gene, and in our case, we were talking about the gene TPP1, which is associated with the subtype CLN2 disease, and that is based upon historical precedents. And so CLN2 disease relates to ceroid lipofuscinosis type 2, or CLN2, and this can be named either by the genetic subtype, by the deficiency of the particular protein or TPP1 deficiency, and then you can also call it by the genetic name TPP1 related disorder. We can see this in a different way, that TPP1 deficiency, again, that's the protein level. At the gene level, that's TPP1 gene dysfunction, which ultimately is called CLN2 disease. And so going forward, I'll be using CLN1, 2, 3 as the most common way to refer to the different genetic subtypes. Prior to molecular genetic diagnoses, again, these were described by age of onset, and there is, at least in the in some cases for CLN1 disease, the most common presentation is infantile onset. For CLN2, most commonly it's late infantile or onset between 2 to 5 years of age, as was in our case. Juvenile is between 5 to 17, and adult onset is 18 years and older. Now, there are exceptions to all of these, and we're increasingly recognizing that these late infantile or juvenile forms may actually have earlier symptoms than initially thought. For our case, it mirrors the natural history of CLN2 disease progression, which has been very nicely described by a large international consortium known as DEMCHILD out of Hamburg, Germany, led by Angela Schultz, in terms of the course of disease ranging from early language delays, seizures that can range from myoclonic, generalized tonic-clonic, astatic, as well as focal seizures, a movement disorder that can initially be seen as ataxia, and you saw that cerebellar atrophy on the MRI, and certainly a progressive issue with the progressive cerebellar atrophy and worsening ataxia over time, but also non-epileptic myoclonus spasticity as well as dystonia can be apparent. And so thinking for non-epileptic causes for abnormal movements is important in these individuals. Ultimately, in 4 years and older, you can see cognitive deterioration, loss of feeding function, and possible need of tube feeding, as well as visual decline and ultimately blindness. Death is, at least prior to treatment, has been anywhere between 10 to 12 years of age, some earlier and some certainly later in the more attenuated phenotypes. These, the initial natural history studies were using this Hamburg scale, which is a very coarse measurement, but is able to readily capture change over time in clinic about different aspects of CLN2 disease function, ranging from motor function, language function, seizures, and vision. However, motor and language seem to be the most stable over time, with less variation from point to point. And you can see how coarse it is, ranging from 0 being no function, either immobile and bedridden, all the way to walking normally, through language being no language at all at 0 to 3 being normal. But that's the current outcome measure that we're using, and ultimately one that I'm eager to see if new outcome measures can be more helpful. The vision loss in Batten disease is quite specific, not exclusive to Batten disease, but certainly when seeing this ring of autofluorescent pattern around the macula, this most commonly is called a bullseye maculopathy and is related to an increased autofluorescence with mild diffuse peripheral hypoautofluorescence. And more recent imaging, namely optical coherence tomography, can be used to capture changes over time in terms of visual function for Batten disease. We talked about how genetic testing was negative for our case, but certainly want to make sure that there's other testing options that are freely, or at least at no cost to patients. Certainly nothing is free, in the sense that this behind the seizure pattern is behind the seizure panel is no charge for individuals 8 years and under with an unprovoked seizure, and at least is funded by a number of different pharmaceutical companies, including one that produces enzyme replacement therapy for Batten disease. So they certainly have a vested interest in finding new cases of Batten disease for use of their product. And de-identified information can be shared, or is shared, with these different pharmaceutical companies. So that is the cost to using this panel, but offers the ability to test 302 genes, including sequencing and del-dup, with a pretty rapid turnaround time. And I use it in some cases, but certainly not exclusively. So when thinking about different genetic testing strategies for epilepsy, we have to think about the range of, or the different types of genetic changes that can cause disease in humans. And we can think about large structural changes, and that's where karyotype is most helpful. And so here we can detect deletions and duplications that are larger than 5 to 10 or greater than 5 to 10 megabases. But it is helpful in determining if there is a large structural rearrangement, where that change happened. So if there was a translocation or a deleted area of a chromosome, especially in balanced cases, it helps us to say, okay, where did the switch happen? Which isn't available to be done on microarray, which is able to tell us on a much finer grain scale, on the order of less than 0.5 megabases, if there's missing or copied information. If you think of this information as a library, our genetic information or genome as a library, you can think of a karyotype being taking out whole sections of books and removing them, rather than a single shelf like a microarray, which would be able to see these more finer grained changes, copy number changes. That's in contrast to more recently next generation sequencing, which is opening up books and looking for letter changes within any given book or gene. And so next gen sequencing, or NGS, is helpful for looking at really detailed changes or single nucleotide variants, or small insertions and deletions that are associated with genetic disorders. So they're all helpful, but in different ways. When considering genetic testing for epilepsy, this is certainly my take and open to others' opinions. But in general, I try to test individuals who have epilepsy plus dysmorphic features, epilepsy plus global developmental delay or intellectual disability, autism, and especially if there's regression with neurologic features. When thinking about epilepsy plus cases, for many of these, if there's a co-occurring significant neurodevelopmental disability, I tend to favor exome sequencing since there are neurodevelopmental panels that may not overlap with your epilepsy panel. And so when you're considering 2 or more panels, I often prefer to go towards exome, as well as if there's a neurodevelopmental disability, also considering microarray and or Fragile X, at least for males. Certainly for medically refractory cases, that's another indication, but if it fits a classic pediatric epilepsy syndrome that is not thought to be related to monogenic causes, like a complex genetic trait, say, for example, benign childhood epilepsy with centrotemporal spikes, and it's initially difficult to control, I'm on the fence about the utility of genetic testing, but certainly if providers or families are concerned, certainly could discuss about the utility of testing. And certainly younger age of onset has been associated with an increased yield of finding a cause, namely less than 1 year of age. And a family history, if it's clearly suggestive of a dominant pattern of inheritance with multiple family members affected between generations, worthwhile testing, but the absence of a family history does not rule out the possibility of a genetic diagnosis. And there are a lot of different epilepsy panels to choose from, over 117, at least listed in one database for different genetic test options. And they can be quite varied in terms of the number of genes included. You saw before that the epilepsy panel from Invitae was about 300 genes, and it doesn't include 3 genes associated with Batten disease. Other genes like other gene panels like Ambry's Epilepsy Next Expanded Panel or GeneDx's Epi Expanded Panel, just large gene panels associated with epilepsy, each have over 900 genes associated with epilepsy. And so we'll talk a bit more about why that matters. There's also the possibility of faster panels, whether a stat epilepsy panel to get results of critically ill epilepsy patients that you think could have medically actionable interventions, whether it's a ketogenic diet or pyridoxine, with a turnaround time of 2 weeks reported, or even rapid genome testing, which has been rolled out slowly, at least on a research basis, and slowly moving forward towards commercial access, at least in California, largely led by Rady Children's Hospital. So is an epilepsy gene panel really the best first-line test for epilepsy? And that, I don't know. And I was talking a little bit about how in co-occurring neurodevelopmental disabilities may make me veer more towards exome with or without microarray rather than epilepsy panels just themselves. And so if you think of an epilepsy panel, again, using as the an analogy of a library, you're selecting out certain books with epilepsy in the title and opening up those books and looking for individual letter changes, or you're looking for rare variants within individual genes associated with epilepsy. And depending on the book or your search strategy, you're either looking at just a handful of books, or you're looking at you're doing a much wider search over many books, or potentially looking at all disease-associated genes, as in exome. Genome sequencing differs from exome sequencing in the sense of including what kind of material within the genetic information you're looking at. So exome only looks at 1 to 2% of all of our genetic information, and genome theoretically, but in practice, does not actually look at all of the additional 99%. And one of the big areas that is of interest for me is looking at these intronic regions. Again, at the DNA level, we have exons separated by introns, which then get spliced out in mRNA processing. And so at the RNA and ultimately protein level, we have just the coding information represented. But on the DNA information or DNA level, we have additional areas or additional nucleotides that aren't typically being read on exome sequencing. And genome sequencing sometimes, but not always, looks at this deep intronic, at these deep intronic regions. So what's the overall yield? This was a paper review led by the Boston Children's Epilepsy Genetics Group, and showed that the overall yield of genetic testing in epilepsy, taking all comers, children, adults, any different types of seizures, again, only reported in the literature, so maybe not necessarily reflective of what's done in clinical practice, since there's certainly publication bias to show a higher yield, but an overall yield of 17%. And that includes, for microarray, about 9%, certainly higher in individuals with neurodevelopmental disabilities. For multi-gene panels, looking at about 19%. And interestingly here, with a higher yield with those with increasing number of genes on a panel. So a 35% yield for those with more than 500 genes on a panel, or in the presence of structural brain malformations. This, I think, has led me to think more about doing these epilepsy expanded panels, whether it's through AMBI or GeneDx. But certainly, I think there's a role for the smaller panels, especially decreasing the likelihood of finding a variant of uncertain significance, which can sometimes be anxiety producing for families. And then exome sequencing, there's a higher yield compared to panels. I don't know if it was statistically significant, but at 24%, and other things like developmental and epileptic encephalopathies increased a yield. Genome sequencing, this 48% is largely based upon just a small study sample, and likely veering towards more severely affected individuals that may not have been representative in the other studies included. So I don't think that this is accurate for genome sequencing for all comers with epilepsy, but certainly certainly intriguing to think that genome sequencing could help identify additional individuals that could be missed on prior studies. And so going back to our case, the Tanya with CLN2 Batten disease with TPP1 deficiency or enzyme deficiency, but without genetic cause, we pursued research-based whole genome sequencing and found that she had one of these deep intronic variants. It was homozygous, or both of her copies of TPP1 were affected, and her parents were each found to be carriers. So this was suspicious. That combined with that there was no data on what was going on in control populations, and it was predicted to influence splicing. We then were able to take some of her blood to GeneDx, a commercial laboratory, and were able to look what was happening on the RNA level. Up here is just a representation of, at the DNA level, we have an exon, we have a splice site here normally, a splice site here normally. And in the case of our individual, what we saw is that with this single switch of a G to an A, within the intron, what happened was that a splice site was created in that region. And so this ended up causing these molecular scissors or splicing factors to end up cutting here instead of cutting here normally. And so combining this exon to this additional information, or this intron, ended up creating intronic retention, or additional nucleotides that weren't previously in the mature mRNA. And what ultimately ended up what this led to was the creation of a stop codon within this particular transcript, and ultimately lack of creation of functional TPP1 protein. And so we're able, with research-based genome sequencing, to show a loss of function genetic variant. ultimately providing a genetic explanation for the enzyme deficiency and ultimately confirming what we already knew, that she had CLN2 disease. So just to review, Batten disease, or the NCLs, are a group of typically recessive neurodegenerative LSDs that can lead to a myriad of neurologic impairment, including behavioral changes, epilepsy, motor, cognitive, language decline, as well as vision loss. Onset can be anywhere from infancy through adulthood, and somewhat depends on the underlying genetic subtype, which are categorized based upon the underlying gene, ranging from CLN1 to CLN14. And in our case, we had CLN2 disease as a result of a TPP1 deficiency, leading to late infantile neuronal ceroid lipofuscinosis. While panel-based genetic testing in epilepsy is common, there's increasing yield with an increasing number of genes on the panel. Certainly need to make sure that if you already know what you're searching for, whether it's pyridoxine-dependent epilepsy, hyperglycemia, or GLUT1 deficiency, or SEN1A related disorder, certainly a smaller panel is better. But if you're not sure, I think not to be scared of doing larger gene panels with appropriate genetic counseling, and with genetic counseling is certainly reasonable. And recognition of the role of exome and genome sequencing, especially as in our case. So moving forward with treatment of Batten disease, there was previously a development of a palliative care framework for Batten disease, of which ranges from focusing on quality of life, early introduction of palliative care for anyone with a life-limiting illness, which includes Batten disease or NCLs, including comprehensive medical management and family support. I think the COVID-19 pandemic has certainly taught us that individuals with neurodevelopmental abilities are especially vulnerable in terms of changes in health status related to access to services. And so while coming out of the COVID pandemic, making sure that these individuals, not only with NCLs, but also with other chronic neurodevelopmental disabilities, maintain access to services remains paramount. In addition, with medical management, there's a lot going on in terms of clinical trials, and families are often asking us, okay, what's next on the horizon? And so increasingly, you all are likely becoming familiar with clinicaltrials.gov, as well as other resources, patient advocacy, community websites, as well as Facebook groups, in terms of how do we figure out systems to help patients get connected to the latest research. And then making sure that not only we're supporting siblings, parents, as well as the individual regarding coping with medical illness, but also making sure that genetic counseling is involved for testing at-risk individuals. The landscape for treatment of lysosomal storage disorders ranges from replacing the underlying enzyme that's deficient, and so that's on the bottom right-hand side. In our case, we have TPP1 deficiency. And so if you just replace recombinant TPP1, theoretically, into the areas that it needs to go in the brain, then you're replacing the underlying defect or problem. You can provide small molecules to stabilize existing enzyme, either through chaperones or other small molecule therapies. You can replace the underlying genetic defect. Okay. Oh. Okay. Well, hopefully you all can still see the screen on those connected via web. But we can, instead of replacing the enzyme, you can replace the gene. And there's discussion about whether this would be a one-time therapy. And if the gene can be stable within the cell, continuously produce the enzyme or protein that's not functioning properly within the cell, as well as discussion about stem cell transplant. Stem cell transplant has not shown to be effective within the NCLs, but we'll certainly talk about some of these others, starting with enzyme replacement therapy. And so first, to understand how enzyme replacement therapy has been helpful for CLN2 disease, want to show you two examples. So this is two siblings from a patient foundation, Noah's Hope and Hope for Bridget. And so as you're watching the videos, we're going to begin to score or see how they're functioning. Noah is the boy, and then I don't know which one is the affected fraternal twin sister. So you can see his ataxic movements of the arms.
Are you getting your cards out? Okay.
He has some reduced language as well. You can hear the slow, somewhat dysarthric speech. And then ultimately, in late stage, without intervention, what this appears like: no language, as well as very limited motor function. And so you could see in the early stages, he appeared to have near normal language and appeared to walk and run normally. And at least it was difficult in the video to say whether or not he had any walking. He had definite clumsiness, whether it was a one with just crawling or he was having some walking, but with difficulty, hard to say. So somewhere between 1 and 2. And then finally, he had a score of 0. And then you saw his language. It was very difficult to hear his language earlier, but how it became recognizably abnormal with a score of 2 and ultimately unintelligible by the final, by the end of the video. And so this scale was used to show efficacy of cerliponase alpha, approved in 2017, to slow the progression of disease in individuals who are 3 years and older. And we'll look at the data here. Well, first, how is this administered? So enzyme replacement therapy for CLN2 disease has to be administered through an intracerebral ventricular reservoir. And so every 2 weeks, the reservoir is tapped to provide the enzyme infusion so that the enzyme goes to the parts of the brain it needs to go. You can see here, after you access the port, you tape it down. And the most common reactions are infusion-related reactions or fever, sometimes vomiting. Seizures, it's difficult to say whether or not they are or are not associated with the intervention, as well as sometimes infection, device-related infection is an important consideration. These issues with ECG abnormalities and bradycardia, later onset or individuals on the severe end of CLN2 disease may end up getting cardiac dysfunction. So how much of this is just secondary to their state of disease is unclear. And so this is looking at combined motor language scores that scale from 0 to 3 added together for a score with a maximal score of 6 and a lowest score of 0. And here you can see in individuals who are treated over 121 weeks, you can see stabilization in disease in these motor language scores compared to historical controls. Unfortunately, this type of therapy does not get to the retina, and so these individuals still become blind. And there's limited data right now on epilepsy, but there is hope that this could be considered as a adjunctive agent to help ameliorate seizures. So what about our case, Tanya? So by 16 years of age, she was minimally interactive with her environment and her motor language score was 0, much like the end of the video that I previously showed. She also required exclusive gastrostomy feeds as well as had chronic respiratory failure. Then her mother was found to be pregnant and chorionic villus sampling showed that she had that the embryo had absent TPP1 activity. The mother was counseled and proceeded with the pregnancy, and ultimately after delivery was confirmed to have CLN2 disease. Now we're in a situation, so this was back in 2021, we're in a situation where we have someone who has presymptomatic or theoretically presymptomatic CLN2 disease. Is there any data to say, could we use enzyme replacement therapy for children less than 3 years of age? And so this is now getting into a novel ground. And in one case series, looking at an older sibling treated at around 4 years of age, there was some decline. Those are the dots later on looking at either motor and language function. But the younger sibling treated at 23 months seemed to be stable throughout the entire course. And so this younger sibling treated at 23 months showed appropriate development and was quite exciting to see. There have been some other reports both at University of Colorado, Lurie Children's, as well as in Hamburg about treating presymptomatically. And that's what we moved to do at NYU. And so have started at around 12 months of age with enzyme infusions that that we're doing in a presymptomatic individual in hopes of preventing the decline that was seen in her sister. What about vision? So Nationwide Children's Hospital is looking at intravitreal injections into the eyes to try to preserve eye health, done every 4 weeks, and they're enrolling by invitation. Enzyme replacement therapy is currently being developed for CLN1 disease, but is not yet in an in-human clinical trial that I know of. We'll move on to talk about gene replacement. The issue with enzyme replacement therapy is that you have to give it every 2 weeks because the enzyme degrades or is processed naturally by the body. So it's a lifelong therapy, which comes with both a cost as well as just significant patient burden. And for gene therapy, there are multiple approaches, both directly delivering the gene of interest into the body or removing a certain cells of interest, typically stem cells, and replacing them or injecting the gene of interest into these stem cells and then replacing the stem cells back in the body to then engraft and produce the protein of interest from those stem cells. And so this has already been commercially available in pediatric neurology, at least in vivo gene therapy for spinal muscular atrophy. And now there's FDA approval for ex vivo gene therapy for cerebral adrenoleukodystrophy. What about for Batten disease? So Cornell published this work about CLN2 gene therapy, where they delivered intraparenchymal injections of a normal copy of CLN2 into the brain of individuals with this condition at 12 different spots and monitored over 18 months. On the left-hand side, you can see the average rate of decline of motor plus language, that 0 to 3 added together to a score of 6. And on the right, you can see that there was some decline of about -1 over the study period. I believe it was over 18 months. But that's in comparison to a greater decline in the natural history or untreated individuals. However, compared to ERT, the decline over a similar period, I guess this is averaged over, score per year, sorry. That was at least compared to a decline of 0.27 points. This is, let me just quickly see. So over a 52-week period, about a 52-week period, it was about the same. For enzyme replacement therapy, there was less of a decline over about a year period compared to the gene therapy. Ultimately, enzyme replacement therapy seemingly doing better than gene therapy, and ultimately this trial or this product is not moving forward to my knowledge. They're currently working on redesigning the approaches, either the particular vector or the mode of administration. A different company is working on a different gene therapy for the same disorder, CLN2 disease, done by REGENXBIO, where they're looking to, they've already treated one individual in Brazil by delivering an intracisternal injection of gene therapy, and are looking to expand to other individuals. And then they've also they're also looking to open a study of eye gene therapy for CLN2 disease at Great Ormond Street in London. Now for CLN3, there have been 4 subjects treated at Nationwide Children's Hospital with gene therapy that on the right from a poster presentation showed overall stabilization in disease compared to a natural history cohort. Though this study is currently looking to move forward, but not currently enrolling patients. According to the sponsors' 2022 comments about it, is that they're looking at higher doses, different promoters, and potentially, instead of an intrathecal injection, an intracisternal injection. CLN6 gene therapy, while there's some evidence of benefit of this trial, the sponsor has decided to discontinue this program because of concern about, despite initial stabilization of disease, not maintained through long-term extension. CLN5 and CLN7 gene therapy studies are currently enrolling, one at Rochester and one at UT Southwestern. So there's still some excitement in the community, but certainly challenging for patients and their families when progress isn't moving at the pace that they certainly hope. I think I will briefly, I will skip antisense oligonucleotides for CLN3, but just to mention that there's incredible work done by Dr. Tim Yu and his colleagues at the Boston Children's Hospital doing an N of 1 gene, antisense oligonucleotide, pretty much designing a specific antisense oligonucleotide for an individual or specific therapy for someone with Batten disease. And so this individual had a very similar kind of change to our cases, where this individual within an intron ended up having a variant that said, hey, cut here or splice here right within the intron. And so ended up including or caused intron inclusion of additional nucleotides and ultimately led to a stop codon in the CLN7 gene or MFSD8. If you can block this area, then you can restore normal splicing, and that's where the ASO comes in, or it's an antisense, meaning it is similar but complementary to the normal nucleotide pattern. And it's just a small section of nucleotides or oligonucleotides, hence ASO. And they're able to design a ASO to block this area and restore normal splicing. That was shown in later work, but overall here, they're able to show that this ASO, when delivered on a regular basis every 3 months at maintenance, a decline in seizure frequency as reported by parents, as well as by EEG, as well as a decline in mean seizure duration, as well as time spent in seizure. Unfortunately, she did pass from her illness a few years later after starting treatment. And now there's mechanisms through NLORM, a nonprofit organization that's largely funded by a company making ASOs commercially to help these N of 1 or ultra rare conditions to move from a patient with a known genetic diagnosis that could be amenable to ASO all the way through delivering an experimental treatment. Could we use this for our patient? Certainly that came across my mind, but going through this process, especially with an experimental therapy when there is a known standard of care enzyme replacement therapy available, the benefits did not seem to outweigh the costs. And so decided to move forward with enzyme replacement therapy for the young patient. For small molecule therapies, I will skip over this just to say there's some in development, and just this is the take-home slide for treatment approaches to Batten disease that range from enzyme replacement therapy to gene replacement, including ASOs and even small molecules. The cost, all of these are very expensive at the end of the day, although small molecules can be theoretically quite inexpensive to make. And depending on the situation, ASOs can be relatively straightforward to make as well. The challenge is moving them to commercial use. Oftentimes the price does not remain inexpensive. Gene replacement is unique in that it's supposed or is expected to be one time, but the longevity of gene replacement therapy is unclear. The route of administration is typically invasive for many of these. Small molecule therapies, if designed correctly, can be orally used, and immunogenicity tends to be a concern for most as well. Right now, the only FDA-approved therapy for specifically for Batten disease, apart from the symptomatic treatments, is enzyme replacement therapy. And so with that, thank you for your time, and we'll open it up for questions. Okay.
That was great, thank you. Dr. Kalani started the lysosomal thing. Is he still with us? Or?
He is peripherally involved, and so he does not have any direct clinical roles.
He started.
Exactly.
Just one comment that I'd like to learn about when to do genetic testing and how to do it, because I think that's an evolving thing with all these things, and I don't totally get it. It might be worth writing a review and an algorithm. It's very easy to do about what your approach is now. But I think that was a good approach, and I don't think anybody's written that I've seen, but I think that would be helpful. And it'll be different next year, and that sort of thing. And then the other is a comment about, you know, the issue of drug companies driving this, which is the only way it's going to go, because the government's never going to fund this stuff. And even though it's all driven by drug companies and money, it's doing something. And so it does work, and that's unfortunately, it is not unfortunately fortunate, it is the reality. And so all this stuff is, you know, the NIH should never fund any of this stuff, and for lots of reasons. And so, you know, the world is changing, including the genetic testing, because of all these drug companies. And we have to realize that it's a, you know, double-edged sword, and it's just a huge change in how we're doing things.
Absolutely.
That's a comment. Question. and get away with it.
So in your patient, initially before your genome testing on the Neuronal, you were looking at mostly enzymatic efficiency. Are there any studies looking at like overall what happens at the time is younger physicians, and if they don't find the gene, they just kind of give up on the program. Is there any literature out there to kind of show the efficacy of using an enzymatic approach in those patients with just have how negative that's on?
I don't know. Certainly, the historical precedent within Batten disease, and I didn't mention this, was skin biopsy, and looking for ceroid lipofuscin deposits, and a lot of research has, or a lot of work has previously, as you were mentioning, about guidelines saying, okay, get a skin biopsy, and then we'll like decide what kind of molecular genetic testing to do. So even just within Batten disease, we really don't have updated guidance about molecular genetic testing first. But I think that's an excellent point that in anyone with a bullseye maculopathy with negative genetic testing, need to think a little bit harder. Now, in that case, oftentimes, like CLN3 disease, where oftentimes vision dysfunction occurs somewhere between like 4 to 8 years of age, and that bullseye maculopathy tends to be what brings them into clinic. You don't have an enzyme to test for. So there it's pushing a little bit harder on what can be done on the genetic fronts, whether that's research genome or other strategies. But certainly if it's a younger infant with vision loss and general decline, certainly would consider TPP1 and PPT1 or biochemical testing for CLN1 and CLN2 disease if genetic testing is unrevealing. But yeah, I'm certainly I'm not a biochemical geneticist, and just being raised in the NGS era, I tend to take a genetic testing approach first, but certainly understand the role for skin biopsy as well as biochemical testing to help supplement the phenotypic or the diagnostic journey. Yep.
We used to skin testing. I wasn't sure about sensitivity and specificity of how well it worked. Is there any data on that? I really wasn't sure how good it was. And it probably was different in different hands, whoever was good at reading it and stuff. But do we have any data with skin biopsy?
I don't know off the top of my head.
I don't remember it, but I wasn't sure how well it was.
Yeah, I have had it. Yeah, like radiology or any other field, it's really in the pathologist's hands, and so really getting an expert pathologist to review it is key. And I've had one case where it was Batten disease. We had a variant of uncertain significance and all the typical clinical features, and a skin biopsy was inconclusive. But certainly certainly it can be helpful, but I don't know the overall sensitivity specificity. For other things like CADASIL, it is quite challenging that there's, even with a skin biopsy, the sensitivity can be relatively low. Oh. I think reading into what their approaches are going forward, I think they were worried about distribution of the gene therapy products, since they were just choosing different areas of white matter to inject. I don't know how diffusely the gene got into, namely like the cortex. And that combined with when you're giving it into the CSF or into the cerebral ventricles, theoretically, you're able to get better flow. Maybe that's why Enzyme was better. Again, I cannot make any statement about more or less efficacious. It was just interesting comparing the different data, although it is not a direct comparison. And also it could be related to the promoter. So even if the gene is appropriate, if it's not turned on appropriately or turned on enough, you just could have too little enzyme around to be effective. And so I think that was another thing that they were going to work on for next steps. And then there's a question during an initial referral encounter, is there any specific pattern on neuroimaging that would help point to a specific, point to a possible diagnosis of NCLs, as often clinical symptoms might be shared with other diseases, including congenital leukodystrophy. So for CLN6 has a typical posterior predominant white matter involvement. So can, as Mao is commenting, can appear almost as a leukodystrophy. Others may not have that, like CLN2 or CLN3. Other features like a cerebellar atrophy, especially progressive cerebellar atrophy with vision loss, seizures of varying types, could increase the likelihood of Batten disease. Okay, thanks.